reliable source. Cardiac glycoside or digitalis glycoside digoxin, linoxin. Respirations. Respiration is the act of breathing. Inhalation or inspiration refers to the intake of air into the lungs. Exhalation or expiration refers to breathing out, or the movement of gases from the lungs to the atmosphere. Ventilation is also used to refer to the movement of air in and out of the lungs. There are basically two types of breathing: costal, thoracic, breathing and diaphragmatic, abdominal, breathing. Costal breathing involves the external intercostal muscles and other accessory muscles, such as the sternocleidomastoid muscles. It can be observed by the movement of the chest upward and outward. By contrast, diaphragmatic breathing involves the contraction and relaxation of the diaphragm, and it is observed by the movement of the abdomen, which occurs as a result of the diaphragm's contraction and downward movement. Mechanics and regulation of breathing. During inhalation, the following processes normally occur. Figure 29 to 16. The diaphragm contracts, flattens, the ribs move upward and outward, and the sternum moves outward, thus enlarging the thorax and permitting the lungs to expand. During exhalation, figure 29 to 17, the diaphragm relaxes, the ribs move downward and inward, and the sternum moves inward, thus decreasing the size of the thorax as the lungs are compressed. Normal breathing is automatic and effortless. A normal adult inspiration lasts 1 to 1.5 seconds, and an expiration lasts 2 to 3 seconds. Respiration is controlled by A. Respiratory centers in the medulla oblongata and the pons of the brain, and B. Chemoreceptors located centrally in the medulla and peripherally in the carotid and aortic bodies. These centers and receptors respond to changes in the concentrations of oxygen, O2, carbon dioxide, CO2, and hydrogen, H+, in the arterial blood. See Chapter 50 for details. Sternum moves outward. Diaphragm contracts. Diaphragm contracts. Ribs move upward and outward. Figure 29 to 16. Respiratory inhalation. Top, lateral view, bottom, anterior view. M29B_Berm 4362_10_SE_CH29.IND496 February 12, 5:51 p.m. Chapter 29 Vital Signs 497. Number 153613 CUST, Pearson O. Berman PG Number 497 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Inspiration and expiration. An adult takes in about 500 ml of air. This volume is called the tidal volume. For further information about pulmonary volumes and pulmonary capacities, see Chapter 50. Body position also affects the amount of air that can be inhaled. People in a supine position experience two physiological processes that suppress respiration: an increase in the volume of blood inside the thoracic cavity and compression of the chest. Consequently, clients lying on their back have poorer lung aeration, which predisposes them to the stasis of fluids and subsequent infection. Certain medications also affect the respiratory depth. For example, narcotics such as morphine and large doses of barbiturates such as pentobarbital depress the respiratory centers in the brain, thereby depress the respiratory rate and depth. Hyperventilation refers to very deep, rapid respirations. Hypoventilation refers to very shallow respirations. Respiratory rhythm refers to the regularity of the expirations and the inspirations. Normally, respirations are evenly spaced. Respiratory rhythm can be described as regular or irregular. An infant's respiratory rhythm may be less regular than an adult's. See Chapter 50 for details about abnormal respiratory rhythms. Respiratory quality or character refers to those aspects of breathing that are different from normal, effortless breathing. Two of these aspects are the amount of effort a client must exert to breathe, and the sound of breathing. Usually, breathing does not require noticeable effort. Sometimes, however, clients can breathe only with substantial effort. This is referred to as labored breathing. The sound of breathing is also significant. Normal breathing is silent, but a number of abnormal sounds, such as a wheeze, are obvious to the nurse's ear. Many sounds occur as a result of the presence of fluid in the lungs, and are most clearly heard with a stethoscope. See Chapter 30 for methods used to assess lung sounds. For details about altered breathing patterns and terms used to describe various patterns and sounds, see box 29-5. The effectiveness of respirations is measured in part by the uptake of oxygen from the air into the blood and the release of carbon dioxide from the blood into expired air. The amount of hemoglobin in arterial blood that is saturated with oxygen can be measured indirectly through pulse oximetry. A pulse oximeter provides a digital readout of both the client's pulse rate and the oxygen saturation. See Skill 29-7 later in this chapter. Skill 29-5 outlines the steps for assessing respirations. Assessing respirations. Resting respirations should be assessed when the client is relaxed because exercise affects respirations, increasing their rate and depth. Anxiety is likely to affect respiratory rate and depth as well. Respirations may also need to be assessed after exercise to identify the client's tolerance to activity. Before assessing a client's respirations, a nurse should be aware of the following: the client's normal breathing pattern, the influence of the client's health problems on respirations, any medications or therapies that might affect respirations, the relationship of the client's respirations to cardiovascular function. The rate, depth, rhythm, quality, and effectiveness of respirations should be assessed. The respiratory rate is normally described in breaths per minute. Breathing that is normal in rate and depth is called eupnea. Abnormally slow respirations are referred to as bradypnea, and abnormally fast respirations are called tachypnea or polypnea. Apnea is the absence of breathing. For the respiratory rates for different age groups, see Table 29-2 on page 487. Clinical alert. An adult sleeping client's respirations can fall to fewer than 10 shallow breaths per minute. Use other vital signs to validate the client's condition. Factors affecting respirations. Several factors influence respiratory rate. Those that increase the rate include exercise, increases metabolism, stress, readies the body for fight or flight, increased environmental temperature, and lowered oxygen concentration at increased altitudes. Factors that may decrease the respiratory rate include decreased environmental temperature, certain medications, example, narcotics, and increased intracranial pressure. The depth of a person's respirations can be established by watching the movement of the chest. Respiratory depth is generally described as normal, deep, or shallow. Deep respirations are those in which a large volume of air is inhaled and exhaled, inflating most of the lungs. Shallow respirations involve the exchange of a small volume of air, and often the minimal use of lung tissue. During a normal, sternum moves inward. Diaphragm relaxes. Diaphragm relaxes. Ribs move downward and inward. Figure 29-17 respiratory exhalation, left, lateral view, right, anterior view. M29B_Berm 4360-10_SE_CH29.IN497 February 12, 14, 5:51 p.m. 498 Unit 7 Assessing Health. Number 153613 CUST, Pearsono, Berman PG Number 498 Title, Kosier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Box 29-5 Altered Breathing Patterns and Sounds. Breathing patterns. Rate: tachypnea, quick, shallow breaths; bradypnea, abnormally slow breathing; apnea, cessation of breathing; volume; hyperventilation, overexpansion of the lungs characterized by rapid and deep breaths; hypoventilation, underexpansion of the lungs, characterized by shallow respirations, rhythm Cheyne-Stokes breathing, rhythmic waxing and waning of respirations, from very deep to very shallow breathing, and temporary apnea, ease or effort dyspnea, difficult and labored breathing during which the individual has a persistent, unsatisfied need for air and feels distressed, orthopnea, ability to breathe only in upright sitting or standing positions. Breath sounds audible without amplification, stridor, a shrill, harsh sound heard during inspiration with laryngeal obstruction, stertor, snoring or sonorous respiration, usually due to a partial obstruction of the upper airway, wheeze, continuous, high-pitched musical squeak, or whistling sound occurring on expiration, and sometimes on inspiration when air moves through a narrowed or partially obstructed airway, bubbling, gurgling sounds heard as air passes through moist secretions in the respiratory tract. Chest movements, intercostal retraction, indrawing between the ribs, substernal retraction, indrawing beneath the breastbone, suprasternal retraction, indrawing above the clavicles. Secretions and coughing, hemoptysis, the presence of blood in the sputum, productive cough, a cough accompanied by expectorated secretions, non-productive cough, a dry, harsh cough without secretions. Purposes to acquire baseline data, against which future measurements can be compared to monitor abnormal respirations and respiratory patterns and identify changes, to monitor respirations before or after the administration of a general anesthetic or any medication that influences respirations. To monitor clients at risk for respiratory alterations, example, those with fever, pain, acute anxiety, chronic obstructive pulmonary disease, asthma, respiratory infection, pulmonary edema or emboli, chest trauma or constriction, brainstem injury. Assessment, assess skin and mucous membrane color, example, cyanosis or pallor, position assumed for breathing, example, use of orthopneic position, signs of lack of oxygen to the brain, example, irritability, restlessness, drowsiness, or loss of consciousness, chest movements, example, retractions between the ribs or above or below the sternum. Activity tolerance, chest pain, dyspnea, medications affecting respiratory rate. Planning, delegation. Counting and observing respirations may be delegated to UAP. The follow-up assessment, interpretation of abnormal respirations, and determination of appropriate responses are done by the nurse. Interprofessional practice. Assessing respirations may be within the scope of practice for many healthcare providers. For example, in addition to nurses, respiratory therapists will check the client's breathing before, during, and after treatment. Although these therapists may verbally communicate their findings and plan to the healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment, clock or watch with a sweep, second hand or digital seconds indicator. Implementation, preparation for a routine assessment of respirations. Determine the client's active ITY schedule, and choose a suitable time to monitor the respirations. A client who has been exercising will need to rest for a few minutes to permit the accelerated respiratory rate to return to normal. Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe appropriate infection prevention procedures. 3. Provide for client privacy. Assessing respirations. Skill 29-5. M29B_Berm 4362_10_SE_CH29.IND 498 February 12, 14, 5:51 p.m. Chapter 29 Vital Signs 499. Number 153613 CUST, Pearson O. Berman PG Number 499 Title, Kosier and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing respirations, continued. Skill 29-5. 4. Observe or palpate and count the respiratory rate. The client's awareness that the nurse is counting the respiratory rate could cause the client to purposefully alter the respiratory pattern. If you anticipate this, place a hand against the client's chest to feel the chest movements with breathing, or place the client's arm across the chest and observe the chest movements while supposedly taking the radial pulse. Count the respiratory rate for 30 seconds if the respirations are regular. Count for 60 seconds if they are irregular. An inhalation and an exhalation count as one respiration. 5. Observe the depth, rhythm, and character of respirations. Observe the respirations for depth by watching the movement of the chest. Rationale: during deep respirations, a large volume of air is exchanged. During shallow respirations, a small volume is exchanged. Observe the respirations for regular or irregular rhythm. Rationale: normally, respirations are evenly spaced. Observe the character of respirations, the sound they produce, and the effort they require. Rationale: normally, respirations are silent and effortless. 6. Document the respiratory rate, depth, rhythm, and character on the appropriate record, see in Skill 29-1. Sample documentation. May 17, 16, 13, 20 respirations irregular, from 18:34/min in past hour. Shallower respirations during tachypnea. Inspiratory wheeze noted. Respiratory therapist called to provide treatment. D. Cadano, RN. Evaluation: relate respiratory rate to other vital signs, in particular pulse rate, relate respiratory rhythm and depth to baseline data and health status. Report to the primary care provider a respiratory rate significantly above or below the normal range and any notable change in respirations from previous assessments, irregular respiratory rhythm, inadequate respiratory depth, abnormal character of breathing, orthopnea, wheezing, stridor, or bubbling, and any complaints of dyspnea. Lifespan considerations: respirations. Infants and children. An infant or child who is crying will have an abnormal respiratory rate and rhythm and needs to be quieted before respirations can be accurately assessed. Infants and young children use their diaphragms for inhalation and exhalation. If necessary, place your hand gently on the infant's abdomen to feel the rapid rise and fall during respirations. Most newborns are complete nose breathers, so nasal obstruction can be life-threatening. Some newborns display periodic breathing in which they pause for a few seconds between respirations. This condition can be normal, but parents should be alert to prolonged or frequent pauses, apnea, that require medical attention. Compared to adults, infants have fewer alveoli, and their airways have a smaller diameter. As a result, infants' respiratory rate and effort of breathing will increase with respiratory infections. Count respirations prior to other uncomfortable procedures, so that the respiratory rate is not artificially elevated by the discomfort. Older adults ask the client to remain quiet or count respirations after taking the pulse. Older adults experience anatomic and physiological changes that cause